tere, mul on hästi hea meel.
Good afternoon. I'm happy to greet you all here on the behalf of the Estonian Health Insurance Fund, all the patients, families, doctors, pharmaceutical companies, and everybody else. You are working very hard to help patients with the rare diseases. We know that these diseases affect few people, but those who are affected, for them, this is a big burden. We know that it's a very long journey to get these treatments. These are very personal and painful stories. On behalf of the Health Insurance Fund, we can assure you that we listen to all parties included. We listen to patients, we listen to doctors, and we take your worries very seriously. Marko, maybe you would like to take over now. So, what are we going to speak about today? Professor Onap contacted me a while ago and told me that, Marko, there is a new law being proceeded, and this also regulates the reimbursement of orphan drugs and potential updates that could be made there. And Professor Onap asked me to come and tell you how this will be applied. When we were discussing it with the professor, we thought that the law would come into force on the 1st of March, which was yesterday. Right now, it hasn't happened. It hasn't been made into a legal act yet. It's going through the second reading in the parliament. We are going to speak about 4 things today. So first, Siiri is going to tell you how much we invest in drugs for rare diseases. Then we are going to discuss what is a rare disease from the Health Insurance Fund's perspective. What's a rare disease? What's an ultra-rare disease? Why do we need these limits? Then we are going to see what it will be different when the new law enters into force, and also how the new drug will reach reimbursement. We have been speaking about how long it takes, and we might be able to make this period a little bit shorter. Yes, there was a lot of talk about how the need for treatment for rare disease is a lot bigger than our current possibilities. Here you can see a chart, and you can see the funding of rare diseases over the past 6 years. And I'm happy to tell you that we haven't been standing still. You can see that the number of patients who are receiving help with the funding of the Health Insurance Fund has increased. So we have 543 additional people. When we look at the funding numbers, then we can see that in 2020, we funded the drugs in the amount of more than 10 million euros. And by now, this amount is more than 4 times bigger. And looking back to previous year, then we can see that 13 million euros of funding was added and 133 new patients. When you have a look at this chart and you see these flat curves, then this is due to the ultra-rare diseases. This is because of the fact that the medicines for ultra-rare diseases are more expensive, and the number of patients is smaller. Every day we work hard towards making as many medicines as possible available to as many patients as possible, and we would like to thank everybody who work towards this goal on a daily basis. And there is another chart which you can't see here, but when we have a look at the treatment bills of these same patients, then we can see an added 17 to 20 million euros. So we could say that every 20th euro that the health insurance gets from the Estonian people reaches the people with rare diseases. So it does have its effect, but we know that there are more and more patients in Estonia with the rare diseases. We know there are about 10,000 people, whereas we only support about 1,000 people right now. What questions did we have in the Social Committee of the Parliament? The question of defining rare diseases in Estonia. We just heard about how in Europe we have a different definition for a rare disease. So an ultra-rare disease is a disease that one person out of 200,000 have, and a rare disease one person out of 50,000. Well, we are willing to pay 3 times more for the orphan drugs for ultra-rare diseases. But we do have to draw the line somewhere. When Siiri was talking in the morning, then she mentioned how they started funding the patient's treatment, and then at some point the health insurance fund took over. We continue our cooperation with the Children's Foundation. This helps us realize what are the most important cases that we need to take over. And while we catch up, the Children's Foundation helps the one who are left out in the rain. For example, there will be a new treatment for that 5 babies will receive. I won't go into detail here. Now, where do we get our data to know whether it's a rare disease or an ultra-rare disease? And I think it's important here to consider different perspectives. For example, when a pharmaceutical company comes to us, they say that the prevalence of this disease in Europe is this and that. So they calculate the potential number of patients in Estonia. But when we see that this is an rare or ultra-rare disease, which requires an ultra-orphan drug, then we ask how many of these questions, how many of these patients we really have in Estonia. So we base our decision on the actual number of patients, not the statistics. We have an example from previous year where we couldn't reimburse the medicines if we hadn't had the register. So it's very important to have the register of people with rare diseases. From our perspective, it means that the funding decisions of ultra-orphan drugs, we have to make about 5 a year. And because it takes a lot of time to proceed these decisions, we have started with the narrower focus very quickly. So how does a drug reach the Estonian market? So first of all, there's the basis for decision. We spoke about the safety and the lack of alternatives. But right now, we have the drug committee. We try to understand the medical effect of the drug. Then the health insurance fund assesses the cost effectiveness. We also ask feedback from the patients, which we haven't received so much right now, but we hope to receive more feedback from the patients in the future. After the drug committee has made their decision, we continue with price negotiations with the manufacturer. if it's a new drug, there aren't many, there isn't a lot of data available about it. Maybe we fix it with a specific patient. And only then do we reach the board of the health insurance fund, who has to make the final decision. Then it goes to the supervisory board of the health insurance fund. Then it goes to the list of health services, and then we will wait for the date for it to enter into force, which takes up to 8 weeks, and then the drug reaches the people of Estonia. So this is why it takes so long. First of all, it depends on the period that it takes to receive the application. That takes a bit more in Estonia than in Europe on average. And it also depends on when the new list of health services, the updated list, enters into force. And that can take a bit of time. So this is how the new law can help. But now let's go to the new legal act. So what will change? Right now, the situation is that we want somebody to come to us and tell us, hey, we have a new drug, this will help Estonian people. But after we have amended the legal act, then we don't need to wait for the pharmaceutical company to come and approach us with the proposition, but we can also receive applications from doctors themselves. This is the largest change. And the second important effect is the following. So first of all, we get the written statement from the doctor. The assessment of effectiveness will come from the Agency of Medicines. We'll still need that. Then also the economic effect from the health insurance fund. We still need to contact the manufacturer, but we might have to contact the manufacturer themselves. Last year, when we wanted to get one orphan drug at a slower price, we had to discuss or have negotiations with manufacturers from different countries. We ended up with, we spoke to people from Croatia and Japan and Portugal, and ended up with the manufacturer from Portugal. Then we need to get the decision from the board of the health insurance fund. If they decide that it's a reasonable drug, we have agreed on the price, and the chairman of the board signs the agreement, the patient will receive the drug. This means that we don't have to wait for the decision of the supervisory board, and we don't need to change the TLL. So this makes the drug available to the patients at a faster pace. I didn't manage to speak for 20 minutes, but I hope there will be questions. I saw a question on chat before. Yes, we do have questions. First of all, thank you very much. Do we have any questions from the audience? I would like to clarify one thing. Which institution in Estonia is working towards a drug that is not represented in Estonia and that is more expensive than set in the regulation? Who is the institution who is responsible for bringing this orphan drug to Estonia? This will be our privilege. We will contact the manufacturer. We have different wholesale companies in Estonia who can help us with that. Some of them are more motivated, some are less motivated, but will manage. Are there more questions from the audience? Thank you for the presentation. I would like to ask about the prevalence. It's not easy to find the prevalence of hereditary diseases, especially with a small population. We have only 1.3 million people in Estonia. Often when parents ask from us how rare this disease is, we say that we don't know. We can look at the world statistics, but it can be very different in different areas of the world. For example, some diseases are very prevalent in Asia, but not in Europe. Are you also planning to specify the prevalence, that the prevalence should be based on the Estonian data, not international data? Because it can happen that the pharmaceutical company will tell you that the prevalence should be 1, but actually we have more patients in Estonia. What have we been doing so far? I know that so far you have asked for our advice, but maybe we should have it set in the legal act as well. Because otherwise, I, as a researcher, have to do my own research into the prevalence, but maybe it should be somehow regulated in legal acts as well. Also, we have been discussing it openly, that there are unknown factors that influence prevalence. We do a very good job in our medicine, which means that some babies with rare diseases won't get born. So this also affects the prevalence. And another very sad aspect, this has to do with Emma and the disease that Emma has. You can Google it during the break. Then we only have 1 child who is alive in Estonia with this difficult, severe diagnosis. Why don't we have other children like Emma in Estonia? The answer is simple. They are all dead by now. So we have to consider real life facts as well. Yes, this is a very important question. Last week we discussed that, and we discussed this question, and I understand from your question that you expect us to make this proposition to the social committee. We should use Estonian data. When we think about Emma, who is the only patient in Estonia, then we know this. We know the fact that Emma is the only one because we get this information from the Rare Diseases Competence Center. Another question online. Somebody says, I have a rare disease that requires treatment with 2 drugs. When there is no effectiveness, when the first drug doesn't work, I have to take another drug that costs 225 euros per week. And my doctor told me that I have to pay for the medicine myself, but my disability allowance is only 600 euros a month. So how should I proceed in this situation? I think I need more details about this story. I don't know the specific case. I don't know what's behind that, but I would like to find out more because this person is been put into an impossible situation. If you have to pay more for the drug than you earn a month, then I really recommend you to approach our health insurance fund. A question online. We have a situation where an experienced doctor required 3 months to put together an application so that her patient would get all the necessary help. And the decision came in 7 months. So should the patient's referral to ambulatory care be simplified? when we refer people to ambulatory care, then there are four things, four criteria. First, the person has to meet certain criteria. There need to be, for the person to be sent abroad for treatment. So yes, there are certain criteria that have to be met. And we also have to look at the money. So if the treatment is too expensive, we can't support that. For example, this morning, the person who proceeds these decisions wrote me saying that there will be two decisions made today. So actually the process isn't very slow. Sometimes it's complicated because we speak about medicines without any clinical studies. So it's very difficult for us to decide if the decision to send a person abroad is justified or not. The amendment will enter into force on the 1st of May. We will have a short training day for doctors before that. And please don't remember the numbers in this question that came from online. There are many cases in which the decisions are made faster. And sometimes it only takes a day. Another question. We assess the number of patients based on the rare diseases register. Not all doctors, not all specialists enter their patients into this register. So some patients might be left out, and some patients with rare diseases will not get funding for the medicines that they need. So first of all, we need an application. So right now, it comes from the pharmaceutical company. After the amendment enters into force, it will be from the doctor. We base our decision on the information that's available. If it's in the register, it's fine. Sometimes it's somewhere else. Somebody writes about their own experience. We have the Children's Foundation and the Cancer Treatment Foundation. Is there a realistic scenario where the health insurance fund will take over the funding of all these treatments? I think that all of us in the society know that the need for treatment is greater than our possibilities and our funds and resources. Right now, we know that not all patients, even with the more common diseases, reach doctors at the right time. So I think that this is something that we should strive towards as a society. I will be honest here, we can't take over all the funding. We know what the Children's Foundation does today. We know what the Cancer Treatment Foundation does. And there are medicines there that we can't fund. Because one of our criteria is that the drug should be proven and it should be allowed to the European market. It's wonderful when a patient is helped by a drug, but if this drug isn't registered in Europe, then we can't fund it. Just one comment from the Children's Foundation. We don't want to be taken over by the state. We are a private foundation, and we would like to continue acting like that. A couple of more questions. How important or decisive is the opinion of patients when we make funding decisions? Patients are very important. But then I have been in the drug committee since the beginning of last year, but there have been only very few drugs where we have heard the voice and opinion of the patients as well. There have been cases like that. And this is very important, especially in the cases where we don't have clinical studies. When a clinical study says that the risk of cardiovascular death goes down by 23%, this is excellent. Then we have actual data. But what the clinical studies don't tell us is what are the patient's daily problems and challenges. This is something that the patients can help us with. This is the extra information we need. Or we would also like to receive patients' input regarding the drugs that they are taking. How does the new amendment change the availability of orphan drugs to patients? Going back a couple of slides, we will receive the application faster, and after the drug has been approved by the board, it will be available. Another question. I have a very naive question. These diseases are very rare. Isn't there a movement on the European level that these decisions could be taken on a pan-European level? Because if the numbers of patients are bigger, it would be easier to negotiate with the manufacturers. Since we only have 1.3 people in Estonia, then we could have more power if we joined our forces with the other countries, right? Is that what you meant? Yes, that would make sense. Today, we also compare ourselves to other countries. And as far as I know, on the Baltic Assembly, the health ministers agreed on cooperating in this field. Another question, what if a drug has been registered in Europe and also taken into use? Then what affects the availability of the drug in Estonia? My doctor tells me that we can't afford sufficient treatment because the funding is insufficient as well. I need more details because we have solidarity in healthcare in Estonia. Another person asks, going for a treatment abroad, what should a patient do who hasn't been diagnosed in Estonia for years? Nobody has been able to make a diagnosis. What should they do? Thinking back to the presentation we had before lunch, how a patient was being sent to another and another and another specialist. When I think about cases where we have sent people abroad, then I can't remember examples like that, but it's a very difficult case. I am an ordinary doctor, and as time goes by, then when I leave this rare disease day, I always live with a positive message, but when I get back to work, this positivity disappears and actually turns into negativity. I have patients who have a disease which is very rare. They are the only person with this diagnosis in Estonia. They can't stand for themselves, and I haven't been able to help them either. And I have more and more patients like this every year. There is gene therapy that is very effective. When you tell me that there are a couple of new patients every year, then I'm afraid that over time there will be tens and tens of people every year. How will we manage? Because I'm sorry for saying that, but the diagnosis is given very quickly in Estonia. So when we wait for 1600 days, then a newborn baby will have died for 100 times before they receive the medication. Could you repeat the question? What was the question? How should we manage in this situation?
Osa küsimusest Siiri saab mõelda, et kuidas me kõik raha, kust me leiame.
Siiri can answer part of the question, but I would like to talk about numbers a little bit more.
Äkki Riho saalis oskab öelda, enne see oli meil 500 ja 800 vahel kõikus on, et üle 1000 need päevade arvud küll.
The number of days should be between 500 and 800. It's not more than 100. So we are trying to make it shorter. I understand the frustration of the doctor. But luckily, it's not such a long period right now. And where should we get the money from? I won't start complaining here about our financial situation. Probably many people here in the audience know that we have to make an agreement in the society about our treatment standard, about the healthcare service we give to the Estonian people. So this is a question of social agreement. I would add that if we look at how much we invest in medicines and where could we save, then if there are more competitors on the market who provide generic drugs, this will bring prices down. So we will have 4.25 million of savings. So this will also improve the situation. I understand that there is a therapy for SMA. We have a screening for newborns, and we have gene therapy for SMA. Basically, what I've understood is that certain forms of SMA can be treated in a moment. SMA 2 and 3 can be treated. With SMA 1, it's a little bit more complicated. Latvia and Lithuania use gene therapy. Why aren't we doing that? It gets more and more specific. Thank you for the question. We are working on it. It's a work in process. Thank you very much. The head of the Health Insurance Fund, Siiri Lahe, and Marko Tähnas. Thank you.